Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Welcome to Unit 3, Nursing Care for Patients with Lower Respiratory Disorder. This lecture focuses specifically on lower respiratory system assessment. Understanding a detailed systemic assessment is the foundation for effective nursing care in this critical area. This unit is vital for your practice as respiratory complications are common and can deteriorate rapidly. We will be using a comprehensive framework to ensure we cover all necessary assessment components. By the end of this session, you will be equipped with the knowledge to meet four key learning objectives. First, we will focus on the urgent task of assessing acute dyspnea. We must use systemic approaches and validated clinical tools to quantify the severity of breathing difficulty. Second, it is crucial to be proactive in identifying high-risk patients. This involves recognizing specific environmental and historical exposures that predispose individuals to lower respiratory disorders. Think beyond the immediate illness to the patient's entire life context. Third, we will detail a comprehensive physical assessment. This is more than just listening to lungs, it is about interpreting every visual and audible cue to determine the patient's true respiratory status. Finally, we will review the most common laboratory and radiology investigations used to confirm a diagnosis and guide treatment for lower respiratory disorders. This knowledge ensures you to anticipate and prepare for diagnosis procedures and interpret the results. Let us briefly review the lower respiratory system, as pathology here directly determines the clinical signs we look for. The lower respiratory tract starts below the larynx and is responsible for two main functions, conduction and also gas exchange. Our assessment must consider the status of both the conducting and the respiratory zones. The conducting zones include the bronchi and bronchioles, which transport air deep into the lungs. The respiratory zone is where the magic happens, the tiny alveoli and the surrounding capillary bed. Pathology in the lower respiratory tract disrupts the function of oxygenation and also ventilation. If we can pinpoint where the disruption is occurring, our interventions will be more targeted and effective. We will break down the specific problems that affect each of these anatomical regions next. Disorders like bronchitis or asthma primarily affect the bronchi and bronchioles. When these airways are compromised, a cascade of issues occurs. First, inflammation is the primary culprit, leading to the classic symptoms of a persistent cough, increased food production, and also dyspnea. This is the body's attempt to clear the irritation. Second, bronchospasm can also narrow the airway via bronchoconstriction, which is a key component of an asthmatic attack. Third, the airway wall itself undergoes mucosal swelling and edema, and there is excessive mucus production, further plugging the tiny airways. Ultimately, all these factors impair gas exchange as air can't easily reach the alveoli. This results in hypoxemia, a condition where low oxygen in the blood, and also hypocapnia, which is high carbon dioxide in the blood. These last two outcomes are life-threatening and require immediate nursing intervention. Now let's shift our focus to the problems at the gas exchange level, which are the alveoli and also capillaries. Conditions like pneumonia, acute respiratory distress syndrome or ARDS, or emphysema can cause direct damage here in the alveoli and capillaries. The alveolar sacs can be damaged or collapse, a condition known as atelectasis. Furthermore, the thin membrane of the alveolar capillary bed itself can be damaged. This damage thickens the exchange barrier or fills the space with fluid, fundamentally impairing gas exchange between the air and the blood. This has dual effect. It leads to reduced oxygen transfer to the bloodstream and inadequate carbon dioxide removal. This imbalance in VQ matching means that even if a patient is breathing quickly, the gas exchange isn't happening efficiently, pushing them towards respiratory failure. Identifying the source of the problems, either airway versus the alveoli, is crucial for diagnosis and treatment. When oxygen in the blood is low, a state known as hypoxemia, the body will mount a systemic response. As nurses, we must recognize these subtle multi-system signs. In the respiratory system, the body attempts to compensate by increasing the respiratory rate, causing tachypnea and a subjective feeling of dyspnea. Cyanosis is a late, severe sign. The most telling early signs, however, are often neurological. Reduced oxygen to the brain presents as restlessness and apprehension. As it worsens, this progresses to confusion and impaired judgment. Remember, restlessness in a patient with a respiratory condition is hypoxemia until proven otherwise. The cardiovascular system also reacts. Tachycardia and hypotension occur as the heart tries to pump oxygenated blood more rapidly. Finally, the metabolic environment shifts, potentially leading to metabolic acidosis due to anaerobic metabolism. Now, let us consider hypercapnia, the state of elevated carbon dioxide (CO2) in the blood. CO2 acts as a cerebral vasodilator, strongly impacting the central nervous system. In the neurological system, early signs include a headache and, in severe cases, swelling of the optic disc called papilledema. Critically, as CO2 increases, the patient becomes progressively drowsy, potentially progressing to coma. Unlike hypoxemia, which causes restlessness, severe hypercapnia causes sedation and a quiet, cooperative, or unresponsive patient. On the cardiovascular side, the patient will still have tachycardia and hypertension, but the hallmark is systemic vasodilation, leading to warm, flushed skin. In the respiratory system, the initial dyspnea is replaced by worsening fatigue, resulting in respiratory depression as the respiratory drive is depressed. The metabolic results of CO2 retention is respiratory acidosis. To ensure no critical data is missed, we follow a systemic three-part respiratory assessment framework. This framework guides your process from the moment you encounter the patient until a definitive treatment plan is established. Part 1 is history taking. This is your foundation. You must obtain a detailed history of the illness from the patient, if they are able to speak, or from a relative. This subjective data helps identify key symptoms and risk factors. Part 2 is the physical examination. This is the comprehensive physical assessment focusing intensely on the respiratory system, assessing for the clinical manifestations we just discussed. This is where you apply your skills of inspection, palpation, percussion, and also auscultation. Finally, part 3 covers investigations. These are the laboratory and radiology investigations necessary to confirm a diagnosis and determine the severity of the problem. We will now go into the specific of each step, starting with the history of the patient's most critical symptoms, which is dyspnea. When assessing a patient or a symptom like dyspnea, use a systemic tool like the PQRST method, which is traditionally used for pain but works perfectly for acute symptoms. P stands for precipitating and palliative measures. You must ask what brought on the dyspnea, such as physical exertion or stress. Equally important, ask what reduces or alleviates the dyspnea, such as rest or medication. Q is for quality. How does the patient describe their breathing? Is it simply shortness of breath, or are there specific types of dyspnea like autopnea, the shortness of breath when lying flat, or the critical sign of paroxysmal nocturnal dyspnea, P and D, which is sudden shortness of breath waking them up at night. R is for region and radiation. For respiratory issues, this primarily applies if the patient is also experiencing chest pain. If pain is present, determine the exact location and if it spreads to any other part of the body. Continuing our PQRST assessment for dyspnea, S stands for severity. You need to quantify the severity. Use a subjective scale like a 1 to 10 rating, or a functional scale like asking if they can walk across the room or speak a full sentence. Always compare the current severity Two previous attacks. Is this the worst they have ever experienced? Are they better or worse than yesterday? This trend data is often more important than the absolute number. Finally, T is for time. This is crucial for distinguishing acute versus chronic problems. Determine the onset. Was the dyspnea sudden or gradual? For example, a sudden onset suggests pulmonary embolism or pneumothorax, while gradual onset might point to heart failure exacerbation or a progressing infection. Also, note the specific duration of the current episode. The total time spent in acute respiratory distress is a key indicator of patient exhaustion. Beyond dyspnea, a thorough cough assessment provides critical values or clues about the lower respiratory disorders. First, assess the basic cough characteristic, note the onset and frequency, and determine if the cough is dry or unproductive or productive. If the cough is productive, proceed to a meticulous sputum or phlegm assessment. This material is a direct diagnostic window. Quantify the amount, note the color, which can range from clear to yellow or green, indicating bacterial infection, and check the consistency, whether it is thick, thin, or frothy. Don't forget the odor. Foul-smelling sputum often suggests a serious bacterial infection like an abscess. Finally, if there is hemoptysis or coughing up blood, note the type. Is it frank blood, pink tinge, or just a streak? This helps differentiate minor irritation from significant bleeding, so noting the amount and frequency is vital. Moving to a proactive part of the history, we must identify the risk factors from the past medical history. First, identify exposure history. This includes a specific allergens for asthmatic patients, types of pollutants, and general environmental pollution. Note a history of serious infections like pulmonary tuberculosis or congenital diseases like cystic fibrosis. Next, specifically quantify tobacco consumption. This isn't a general "do you smoke?" It requires details, the number of cigarettes per day and the total years of smoking. Also ask about attempts to quit, which indicates patient readiness for healthy teaching. Finally, identify previous severe respiratory illness. A history of frequent exacerbation, prolonged steroid use, or a prior ICU or H2 admissions requiring ventilation is key to identifying high-risk patients who may deteriorate quickly. The third component of our history is the family and also psychosocial history. Start with family health history. You need to actively inquire about the health status of the patient's parents and siblings. This is to identify any genetic predisposition or familial patterns of respiratory illness, such as family history of hypersensitivity predisposing them to asthma. Next, the psychosocial assessment is crucial. A chronic or acute respiratory disease impacts every aspect of life. You must evaluate the availability, and adequacy of their social and family support system. Assess the impact on activities of daily living. Can the patient still perform daily tasks like bathing and dressing? Critically evaluate their psychosocial well-being and the emotional and psychological impact of the disease. Finally, identify their current coping mechanism to see how they manage stress and adapt to their condition. This holistic data informs our education and support intervention. Moving to the physical examination. We start with the most telling signs. First, level of consciousness, LOC, and mental status. This is a continuous assessment. Early distress manifests as an increased level of anxiety, often accompanied by restlessness. This combination is an early warning sign of cerebral hypoxia and impending arrest. Paradoxically, a change to confusion or uncooperativeness often indicates hypercapnia or CO2 retention, and a change to somnolence or quiet cooperation is a dangerous sign of worsening respiratory failure. Second is patient positioning. Patients in acute dyspnea will instinctively actively adopt an upright or tripod position, leaning forward with support, because this maximizes chest expansion. A key clinical note is that the lower the bed position the patient can tolerate, the better their breathing status. This is a simple but vital assessment for tracking improvement. The third and arguably most fundamental part of the physical exam is the respiratory rate, RR. You must count the respiratory rate accurately over a full minute. Do not estimate. The normal range is 12 to 20 breaths per minute. We must be alert when the rate is over 25 breaths per minute, as this indicates significant effort. The danger zone is over 30 breaths per minute. At this severe tachypnea rate, a critical warning comes into play. The respiratory muscles can fatigue very quickly, leading to the risk of respiratory arrest. And remember, if the rate suddenly drops from a high rate to bradypnea, or less than 10 per minute, this is a profound warning sign of impending respiratory arrest. This decline in rate means the patient has exhausted their effort and is crashing. The fourth area is a meticulous assessment of the respiratory pattern itself. Rhythm. Is it regular or is it irregular? Irregularity with periods of apnea is an extremely dangerous sign that should trigger an immediate escalation of sign or of care. Chest expansion. Does the chest rise with symmetry or is there asymmetry? Asymmetry suggests unilateral problems like a large pneumothorax, effusion, or splinting due to pain. Thirdly is the volume. Is the breath shallow or of increased depth? Rapid and shallow breathing is ineffective and quickly leads to muscle fatigue. Pursed lip breathing. This pattern where the patient exhales slowly through pursed lips is a sign that they are actively trying to force expiration. It is highly indicative of obstructive diseases like COPD, where expiration is difficult. Our fifth area is the accessory muscle assessment, which is a powerful indicator of effort. Normally, breathing uses only the diaphragm. When the patient is in distress, they recruit accessory muscles. Look for the use of the sternocleidomastoid muscles in the neck and the abdominal muscle. Also observe for recession, the pulling inward of the intercostal muscles, sternum or supraclavicular areas. The shoulder muscles such as scaleneus, pectoralis major and trapezius may also appear prominent and raised. Once you observe these, determine the duration of use. The crucial clinical significance here is that the longer and harder the use of accessory muscles, the higher the risk of respiratory failure or arrest. This is because these muscles are not designed for sustained work and will quickly lead to muscle fatigue and patient exhaustion, reflecting the severity of respiratory distress. Observing the use of accessory muscles during physical examination provides insight into the patient's respiratory effort and potential distress, guiding further assessment and care. Next, we have two quick but vital inspection-based assessment. The sixth is to assess the patient's ability to talk. This provides an instant functional grading of their distress level. If a patient can speak a complete sentence in one breath, their status is considered normal. If they can only speak a phrase in one breath, they have moderate dyspnea. If they are reduced to speaking only a single word in one breath, this is severe dyspnea. And of course, being unable to speak all indicates very severe dyspnea. The seventh area is to check the color of the skin and mucous membrane. Observe for pallor, progressing to ashen gray. This is an earlier sign of distress caused by peripheral vasoconstriction in an attempt to shunt blood to vital organs. Cyanosis, or the bluish discoloration, is a late sign of severe hypoxemia. Never wait for cyanosis. It is a sign you have missed the earlier warning cues. The eighth steps involves assessing breath sound. Start by listening for sounds audible without a stethoscope, such as wheezing, which signals lower airway narrowing, gargling, which is often due to secretion plugging the upper airway, and stridor, a high-pitched, harsh sound indicating a life-threatening upper airway obstruction. Next, perform lung auscultation. Listen for reduced air entry, indicating poor ventilation or adventitious sounds like crepitation and crackles, which suggest fluid or inflammation in the alveoli. Always note the location and progress of these sounds. Finally, hit this critical warning, a silent chest, meaning you hear no air movement despite the patient's effort, is one of the most dangerous signs. It indicates very severe airway narrowing where air is no longer moving significantly in respiratory arrest. The ninth part of our physical exam integrates the assessment of other vital signs. Pulse oximetry is essential. Report any reading SpO2 less than 95% for general patients or less than 90% for COPD patients whose baseline oxygenation may be lower. Assess the pulse. Tachycardia, often over 110 beats per minute, is a compensatory mechanism. Also note any reduced pulse strength, which can indicate circulatory compromise. ECG monitoring is vital as tachyarrhythmias are a key warning sign of cardiac strain due to hypoxia. A high fever, particularly over 38.5 degrees Celsius, is a sign of an active infection like pneumonia and requires further investigation. Finally, monitor blood pressure. A trend of a narrowing pulse pressure or the difference between systolic and diastolic pressure can be an early sign of shock or severe volume depletion. This slide reiterates the detail required for the cough assessment, emphasizing that this is a continuous monitoring point. Remember the basic assessment points, the onset and frequency, and categorizing the cough as dry or productive. But our true nursing skill comes into play with the productive cough assessment. We document the specific characteristic of the sputum or phlegm, the amount, color, consistency, and odor. A change in any of these, particularly to a green color or foul odor, suggests worsening infection. For hemoptysis, we must note the type, whether it is frank blood or a streak, the amount and the frequency as well. This ongoing documentation is essential for evaluating the effectiveness of expectorants, antibiotics, and airway clearance technique. These slides provide a powerful summary of the clinical signs of respiratory distress. This is your rapid checklist when you enter a patient's room. On the respiratory side, look for being breathless at rest and appearing restless or anxious. The positional cue of preferring Paulus position. The functional cue of pausing for breath at every word. A high rate tachypnea greater than 25 breaths per minute. The mechanical cue of labored breathing with use of accessory muscles. On the cardiovascular and other signs side, check for tachycardia greater than 110 beats per minute, the skin cue of being pale to ashen gray, the critical SpO2 values, less than 92% on room air, poor perfusion signs, prolonged capillary refill time, and being cold, clammy, and sweating. Finally, the overall observation that they look tired or exhausted. A patient who looks exhausted is at very high risk. We now move to the part 3 of our assessment framework, the diagnostic investigations. We start with the simplest, most universal test, which is pulse oximetry. The definition is straightforward. It is a non-invasive method for continuous monitoring of the oxygen saturation of hemoglobin SaO2. This measurement is displayed as SpO2. Its clinical application is invaluable. It provides a real-time assessment of the patient's oxygenation status. It allows for the immediate detection of hypoxemia and is the primary tool we use to monitor the effectiveness of any respiratory interventions, such as oxygen therapy or nebulizer treatments. The SpO2 is a fast trendable number that should be incorporated into every set of vital signs for patients with a respiratory disorder. Now we look at capnometry. This is a more specialized monitoring tool that measures EtCO2 or end-tidal carbon dioxide. The definition of a capnometer is an instrument for monitoring both the breathing rate and, more importantly, the adequacy of ventilation. Unlike the pulse oximeter, which only tells you about oxygen, the capnometer tells you about ventilation. Its mechanism involves a sensor that attached to the endotracheal tube in intubated patients or via nasal cannula for non-intubated patients and measures the partial pressure of carbon dioxide in the expired gases. A rising EtCO2 signals that the patient is retaining CO2, a state of hyperventilation that often precedes a drop in oxygen. This makes it an excellent early warning tool for impending respiratory failure. A critical investigation is the arterial blood gas or ABG. You must know the normal ABG values. pH is normally 7.35 to 7.45. The respiratory component PCO2 is 35 to 45 millimeter mercury. The metabolic component HCO3 is 22 to 26 milliequilibrium per liter. Use the Rome mnemonic for initial interpretation. R is for respiratory and O is for opposite. If pH and PCO2 move in opposite directions, for example, pH high and PCO2 low, it is a respiratory alkalosis. If pH and PCO2 are opposite, pH low and PCO2 high, it is a respiratory acidosis. M is for metabolic and E is for equal. If pH and HCO3 move in the same direction, for example, pH high and HCO3 high, it is a metabolic alkalosis. If they move equal, pH is low, HCO3 is low, it is a metabolic acidosis. After determining the primary acid-base disorder, the next step in ABG interpretation is determining the state of compensation. This tells us how effectively the body is coping. Uncompensated, this is when the CO2 or HCO3 is still normal. It means the body has not yet begun to compensate for the acid-base imbalance. Partially compensated, here nothing is normal. Both the PCO2 and HCO3 are abnormal, meaning the body is attempting to compensate, but the pH is still abnormal. Compensated, on the other hand, is the most successful state where the pH is normal. Even though the PCO2 and HCO3 are abnormal, the body has successfully compensated and restored pH to the normal range. Understanding these states is crucial or important for participating the severity and duration of the patient's respiratory disorder. Let us finalize our ABG review by combining the expected patterns for the four main disorders. Respiratory acidosis caused by the hypoventilation. The pH is low because the respiratory component PCO2 is high. The compensatory buffer HCO3 will be high or normal. Respiratory alkalosis caused by hypoventilation. The pH is high because the respiratory component PCO2 is low. The compensatory buffer HCO3 will be low or normal. Metabolic acidosis caused by renal or organic acid issues. The pH is low and the metabolic component HCO3 is low. The respiratory system compensates by making the PCO2 normal or low. Metabolic alkalosis caused by excess base. The pH is high and the metabolic component HCO3 is high. The respiratory system compensates by making the PCO2 high or normal. These patterns are your roadmap to understanding the underlying physiology. Beyond ABGs, numerous other investigations are crucial. Laboratory studies, this includes sputum FEME and CNS for identifying and guiding treatment for infections. We also look for AFB or acid-fast bacilli for tuberculosis or send samples for cytology to look for malignant cells. Invasive procedures like thoracentesis, lung biopsy, and bronchoscopy provide direct access for diagnosis. Imaging studies, for example, advanced imaging includes the CT scan and MRI thorax for detailed structural views, the PET scan for metabolic activity, and the VQ scan for evaluating ventilation to perfusion mismatch. Pulmonary function tests, the most common is spirometry, which measures the volume and speed of flow of air the patient can inhale and exhale, helping to classify obstructive versus restrictive diseases. Transitioning now to the nursing care phase, your assessment directly informs your priority nursing diagnosis. These are three of the most critical diagnosis one in effective breathing pattern. This is linked to the loss of adequate ventilation and is evidenced by your observation of overexertion and excessive muscle use. Interventions focus on reducing effort and improving mechanics. Diagnosis 2, impaired gas exchange. This diagnosis is frequently related to excessive or thick secretions or mucus plugging. Interventions focus on airway clearance, suctioning, chest physiotherapy, and humidification. Diagnosis 3, a separate but related impaired gas exchange. This one is related to decreased passage of gases across the damaged alveolar capillary unit. It is evidenced by your SpO2 monitoring, specifically decreased SpO2 levels. Interventions focus on maximizing oxygen delivery and improving perfusion. Here are 3 additional highly relevant diagnoses for patients with lower respiratory disorders. Diagnosis 4, the patient reported symptoms of dyspnea becomes its own diagnosis when it significantly impacts quality of life and it is directly related to impaired gas exchange. Interventions here target patient comfort and effective positioning. Diagnosis 5, risk of reinfection. This is often related to an altered immune system secondary to the effect of medication. Many respiratory treatments involve steroids or immunosuppressant, making infection prevention crucial. Diagnosis 6, lack knowledge. This is critical for managing chronic conditions like COPD or asthma. The lack of knowledge is related to self-care and necessary lifestyle modifications such as proper inhaler technique or smoking cessation. This diagnosis guides our patient education plan, preparing them for discharge and independent management. Finally, we cover additional nursing considerations that are often overlooked in the urgency of respiratory distress. In the fluid and nutrition domain, patients who are struggling to breathe often minimize eating and drinking, leading to a diagnosis of dehydration related to poor oral intake. Dehydration also thickens secretion, making the respiratory problem worse. This poor intake similarly leads to imbalanced nutrition related to poor oral intake. We need to ensure adequate calorie and protein intake to support healing. A diagnosis of case of deficient fluid volume is also present, particularly when the patient has a fever, leading to increased insensible losses. Aggressive fluid management is essential, often requiring intravenous support. Under infection and complications, we have 2 related diagnoses for fever. Fever can be related to fluid loss, which is treatable cause that requires hydration. Alternatively, fever is often related to infection, which requires antibiotic or antiviral treatment. It is crucial to differentiate these causes. Finally, consider the serious complication of risk of thrombophlebitis. Patients are often immobile and require intravenous access. This risk is primarily related to poor aseptic handling technique on the IV cannula. As nurses, maintaining strict aseptic technique is our responsibility to prevent this complication. Our last set of nursing diagnosis addresses the holistic care of the patient. Chronic pain is a possibility, especially pleuritic chest pain, which is severe at the chest during inspiration. Pain management, including splinting the chest during coughing, is essential. Fatigue is almost universal and is often related to the treatment itself, for example, side effects of medications or the sheer effort of breathing. We must prioritize rest and schedule care around energy levels. Finally, the risk of disturbed self-concept is high, particularly for patients facing permanent changes in lifestyle. Chronic respiratory disease forces dependence and limitation. Our role is to provide compassionate, realistic education and emotional support to help them adjust their self-image and lifestyle. That concludes our in-depth session on lower respiratory system assessment. We have covered the systematic PQRST method, identified critical signs of respiratory distress, interpreted complex ABG patterns, and detailed a comprehensive list of diagnostic tests and priority nursing diagnosis. Remember, a thorough assessment is your most powerful tool in preventing respiratory arrest. Please use this framework in your clinical practice. Thank you for your attention and active participation. I am now open to any question you may have. Thank you.